And luckily, there's additional trials that have accrued looking at a more of a maintenance type strategy as well following chemotherapy. So we will gain some important answers to this question at some point in the next few years. As soon as these trials read out.
You know, Matt Gulsky presented the chemo followed by pembrolizumab maintenance trial at ASCO this year, and I thought the data were, compelling to keep a patient in a response, use these agents sequentially, more in a maintenance fashion, rather than giving them all, combination-wise up front.
And I think just one other point on that is chemotherapy, there's a limit to how much we can give before building in a break or switching to something else. Immunotherapy, it seems to be if it's working so far, we can continue it as long as it's tolerated. And so thinking about those differences in terms of durability of response and ability to continue therapy are important, I think, underpin how we interpret these trials we just spoke about.
Yeah, I think it's definitely exciting what we've seen with immunotherapy and the duration of response that we've seen with pembrolizumab showing a median duration of response second line of over 2 years, nivolumab similar data. There was the landmark analysis of the Checkmate 275 data showing if you had a complete remission in the metastatic second line state, you actually did extraordinarily well. So it's very possible that durability and depth of response may matter. So giving chemotherapy to induce a response followed by something to maintain it, it feels a little bit like we're treating leukemia now, or perhaps.
The key question in that setting, though, in my mind, is how long do we keep these patients on, right?
Yeah.
Because these immune-related adverse events can really occur anytime, even years into treatment. And so there's still not enough prospective data, I think, to inform us about when we can stop therapy, particularly for those patients who have complete responses or very deep partial responses and who are, 2-3 years into treatment.
So it's certainly very exciting. What do you think, Gordon? Is it time to give this neoadjuvant?
It's interesting. So I mean, from a as you know, I mean, based on Bart Grossman's initial data, which has kind of changed our practice patterns as it relates to management surgically for patients with muscle-invasive disease, the Pure 01 trial would suggest that, we're seeing, kind of complete pathologic responses, which are superior to dose-dense MVAC, in some cases. So it would suggest potentially that, yes, this might have a role there for the appropriately well-selected patient in the neoadjuvant setting. And so that, I think, is not ready for prime time, obviously, but it does, raise some additional, I think, intellectual questions around, which patient and at what time to institute this therapy. It's really changed the landscape of how we manage bladder cancer.
And certainly there's several clinical trials that are now open and accruing patients studying the same idea, chemotherapy with immunotherapy as a neoadjuvant treatment to try to enhance the clinical benefit earlier in the disease space. But there's other options coming up as well. And, Tien, did you see any of the interesting ESMO data on any other frontline combinations?
Well, I mean, we were really impressed by the enfortumab vedotin with pembrolizumab trial that Chris Holmes presented, the EV-103 study, where the objective response rate was somewhere around 70% in these frontline cisplatin-ineligible patients, and disease control. So if you take everyone with stable disease or better, it was about 91-92%. So very impressive data early on. Obviously, single cohort phase 2 study. So we will need to see more patients and randomized to standard of care current controls. But I think very promising for an active agent like enfortumab vedotin.
So it sounds like enfortumab is going to be a player in the future. What do you think, Betsy? Anything else exciting coming up through the trials?
Sure. So there's other metastatic trials looking at novel agents. I think sacituzumab govitecan, if I said that right, IMU-132 showed, again, initial impressive data in terms of response. It's an antibody-drug conjugate targeting a different marker than enfortumab vedotin with a different linker toxin and a different toxicity profile. So I think, as we think about these agents, the question I'll be asking is how different are they from one another? If one doesn't work for a patient, can another one then have success or not? Kind of the same questions we were asking around the slew of PD-1 and PD-L1 inhibitors in this space when they all came at the same time. So I'm optimistic that these are different enough that we can have multiple treatment options for patients with urothelial cancer to look to.
Yeah, maybe we can be a bit more precise about our definitions too. So enfortumab vedotin targets Nectin-4, antibody-drug conjugate gets into the cell and acts via MMAE, which targets microtubule proliferation and extension, and so it really helps in the cell cycle. And then, as you say, sacituzumab is more TROP2 targeting, gets in and acts as more of a irinotecan sort of topoisomerase inhibitor. And so very different mechanisms, both by which they target the cell and then also by which they impact cell proliferation. So I think we're going to need to learn more about these agents and the differences in, is it urothelial expression of these antigens on the cell surface when it gets into the cell, how much that inhibits in urothelial cells and then also in normal tissues, right, and off-target effects. And are these, they seem to be quite tolerable, but are there differences in their side effect profiles?